So the question is, if they've got a bad history, but their biomarkers are negative and their EKGs don't have any changes, can we still tuck them into the OBS unit for a chest pain pathway instead of admitting to cards?
Yes, if they have known coronary artery disease. A few years ago, cardiology realized that, we have an accelerated diagnostic protocol essentially, and so we can get things faster than they could get it on the floor. So they came to us and asked us, they said, look, we have, an 85% negative stress test rate on these certain patients, which are the ones you're describing. And you can get this so much faster and get them out of the hospital quicker, and we will follow them up so you don't have to worry about that. We'll take care of it. And so we came to this agreement that we have an accelerated protocol. We can get things much more efficiently and faster. So let's try and do the best thing for the patient, get them out in, less than 24 hours to 36 hours versus their 72 hours. And so we made that decision that we were going to do that. And then, part of my job is to monitor that to see how well we're doing. And we didn't really have much in the way of problems. Now, you do run into some problems when you pick people that have known coronary artery disease, that have negative troponins and non-diagnostic EKGs. You do run into some problems if the patient has a really high risk, like I said, it's clearly, unstable angina. They were walking, a mile a day, and then all of a sudden they can only walk to the mailbox, then they can only walk to the bathroom, and then they come in. That's clearly, a very high risk story. So putting those patients in there raises the risk, and I'm going to let Dan talk about this. That raises the risk. So your pretest probability goes way up for that stress test, which means that your stress test isn't quite as valid. You want to take that?
Sure. So I can't lecture ever without mentioning Thomas Bayes. So I'm going to do it again. Bayesian, you got to think, what's their pretest likelihood of disease? So if it's through the roof, that you're like, wow, this is a really great story for it. Even if they didn't have EKG changes or troponins that were positive or anything like that, I would still admit them to cards. And the way I approach it is, if I had a negative stress test sitting in front of me right now, if I was a cardiologist, would I discharge them from the hospital? Because that's basically what you're doing on the chest pain pathway. You're saying, I'm going to get this in 12 hours or so. I'm looking for a negative stress test, negative serial EKGs, negative troponins. Unfortunately, unstable angina is a really tricky thing to figure out. It's really hard to define, and people define it differently. And so if you've got a really good story where you're like, man, this guy's got increasing dyspnea on exertion, it feels very much like cardiac pain, it gets better with rest, you're probably not going to pick up much on this guy by just getting tropes and EKGs. You might pick him up on a stress test, but it's kind of dangerous to put someone with unstable angina on a stress test. Like, you're not supposed to do that. So if you're not willing to discharge them if you had a negative stress test, then you should not be putting them on the chest pain pathway, because that's likely what will happen if someone doesn't miss that, wait, this story is terrifying and they need more.
So talk about, while you're there, talk about how pretest probability affects your outcome if you have a test that's not 100% specific. So if you have a test, let's say stress test, is 90% specific and 90% sensitive in our cardiology. Let's just say it's that, and other cardiology units maybe 85. But if you tell the difference between your outcomes, if you have somebody that has a 3% risk of a positive test versus somebody that has a 25% risk of positive test.
So as Matt points out, if you have a pretty high risk, if you think of a 25% risk of ACS, this is a really high risk patient. This is someone that is like clicking all the boxes, okay? Very few of your patients that come in with chest pain, even in the C rooms, are actually at 25% risk of ACS. Our typical chest painer is going to be well under 10%. So that's kind of your baseline. So this is the person that you're really thinking, man, this sounds bad, is going to be a 25%er. The likelihood ratio of a exercise treadmill stress test is about 2, which I'll just tell you is garbage, okay? It doesn't change it very much at all. So you're going to take that 25%er and put them somewhere on the order of 10 to 15%, okay? Which is still too high to discharge. You're an idiot if you're discharging people from the ER with chest pain that has a 10% risk of ACS. There's a word for that guy, and it's defendant, okay? It just is not going to go well for you. Now, take that with someone that's got a 2% chance, okay? Now you're kind of more in the neighborhood of where an exercise stress test might help you out some, okay? Some of the other stress tests that they like to do, the nukes and stress echoes and things like that, are a little bit better, so they have likelihood ratios of 4 or 5. Still, you're not going to get low enough with someone with a 25% pretest probability. You're not going to get them low enough to that rough area where we feel comfortable discharging them. Unlike with PEs, where we have done a lot of work saying, hey, if you're higher than 2%, we should test and treat you. If you're less than 2% risk of PE, we're going to do more harm than good by testing and trying to figure out if this is a PE. We haven't really done that with chest pain in this country, which is disappointing, because if they give me a number saying, look, I want you to miss less than 0.5% of chest pains for ACS, I can tailor my tests for that. Unfortunately, I cannot do that with the current legal climate of you're never allowed to miss a heart attack ever, which is kind of what a lot of lawyers operate under, unfortunately. So basically, you take the pretest. This is a common nomogram. There's a logarithmic scale here. The problem with using these likelihood ratios is that most people are used to thinking in percentages. So if I tell you this guy's got a 5% chance of acute coronary syndrome, you process that pretty well. Unfortunately, in order to use likelihood ratios appropriately, you have to convert that back and forth. This is a nomogram that was part of one of my other lectures, actually, where you can take your pretest probability of like 3%, and it will cross this point right here that's going to have a logarithmic scale to end up with a post-test probability. Okay? I can tell you after doing that prior lecture that if you've got someone with a greater than 10 to 15% risk of ACS, you will not be able to rule them out, in my opinion, adequately with the chest pain pathway, period. None of the stress tests, none of the serial biomarkers are really going to get you there if they're more than about 15% pretest likelihood. So you should not be tucking those folks in.